morning, everyone. Welcome back for our last nephrology grand rounds here of the calendar year, excuse me. And we'll be back in 2025. And this is actually a special nephrology grand rounds, one of our joint adult and pediatric nephrology grand rounds. So welcoming our colleagues in the pediatric sphere. We wish we had more opportunities to join with you guys, but thank you for coming today. We're right at 8 a.m. now, so I think we can maybe go ahead and get started while everyone kind of trickles in. So we'll have two excellent talks here this morning. First, we're going to start off with Dr. Raj Munshi from Seattle Children's Hospital. And so if you join me, give me a warm welcome.
Thanks, Daniel. I hope this sort of garners a good discussion. I already started having a great discussion with Daniel this morning about who should be more clinically depressed. He's a Carolina Panthers fan. I'm a Giants fan. Unfortunately, I think I'm taking the trophy right now. But enough about my depression. Let's move on to this talk. So I'm hoping to talk about transition for dialysis patients. From pediatric to adults. And this is something that is a recent passion of mine and transition, and I'm finding it really difficult, and I'm hoping to get advice from all the brains here. So we will start with the case, give some background of things that people have been thinking about now for a while now. The work that we've done with our SCOPE collaborative, which is a collaborative of pediatric dialysis centers sort of working together to prevent infections, but this has been some of the work that's been a subgroup of it in current state. So we have a 22-year-old Black male who has end-stage from obstructive uropathy, adopted as a child and had a kidney transplant that lasted about 10 years. And he's been on hemodialysis now since 2017. He's been now estranged from his adopted and biologic families. And I put the biologic family second because after he was estranged from the adoptive, we try to connect him to the biologic family. And then that also did not work out. He's currently homeless, has significant learning delays at the 3rd grade level, and I'm probably giving him more credit than he may be able to do. And he's resistant to any state-appointed guardian. So as we sort of consider this case, we should think about, is he stable for transfer, or will he ever be? Should he be considered an adult? And what skills would give him a chance to be successful when he does transfer to the adult side? So in 2011, the international pediatric and adult nephrology community came together and wrote a consensus statement articulating the need to have a transition program for patients with kidney disease. And they articulated that transition should be a purposeful process intended to prepare adolescent and young adults to be able to accept responsibility for his or her disease management. And then transfer was defined as the act of moving medical management from the pediatric to the adult provider. So here, transition really is developing the skills, and the transfer is the physical act of moving responsibility from the pediatric to the adult side. In 2018, all the academic societies sort of came together, and so they looked at more brass tacks on what you need to do to try to have successful transitions and transfer, and they stressed the importance of a shared responsibility between the pediatric and the adult providers towards a successful transition and transfer. And both in 2011, 2018, there were lots of cool diagrams, but in 2011, the Venn diagram was really, you have to think about the patient, the young person, the pediatric unit, and the adult unit. You need support from their family members. You need support from both the pediatric and the adult side. You want to have somebody who is a champion for the transition. You need somebody with the skills from a psychosocial side to sort of help them with the successful transfer. In 2018, they came up with the 6 core elements, really starting from almost like you sort of graduating throughout high school and going on to college, steps that you have where you sort of develop the skills along the way. And then after you transfer to have this bidirectional talk, and the transition will continue after you transfer to the adult side, the skills that you need to be successful. The other thing that they articulated is that transfer should occur during a stable phase of their life. And so I think Dr. Harshman is going to maybe bring up the question, will it ever be a stable phase of their life during that time? And then when people come together and be like, let's see how we're doing. Are we really good with this transition program? Came out in 2011, the consensus statement. We'll check about 10 years later. And what we found is most of the youth are not receiving transition preparation according to surveys. And what that means for our dialysis population, if you look at the USRDS data, less than 18 is 0.4% of the total population. When we look at combined less than 44, it's about 5%. So the patients are going into from the pediatrics to the average age of about 50 to 60, and they're a very small minority. And so the developmentally, just for a normal healthy adult in that time is going to be completely different. The 60-year-old who has a different vision of their life, how they sort of approach life, what the goals of life are going to be completely different than that patient that's going from the pediatric to the adult side. And that's reflected in outcomes. When we look at hospitalizations and emergency room visits, less than 44 have the highest rates of using that care. So definitely things that we need to improve. So then when I think about this, when I think about my patient, like, well, what is the definition of an adult and how should we approach it? And, you know, now that AI tells us everything, this is who I ask. I'm like, hey, what's the definition? And then you have different approaches, like should it be cultural or religious perspective of when you're an adult? If you you know, I was privileged to attend Ari's children's bar mitzvah. I'm like, well, they're an adult, and you know, they're 13, so here you go. Good luck. Or is it a legal definition? Civic responsibilities, when you can vote, when you can start to drink. And so the history in the United States actually during the colonial time was, well, if you can bring bread to the table and you have responsibilities, you're an adult. Then it became 21. And then when the World War II, where they're like, we need more bodies, so let's drop the times where you can enlist in the draft to 18. And people were like, well, if I'm young enough to die for my country, I should be young enough to be considered an adult. And so that's when in 1970s, the 26th Amendment led to the drop in age of adult to 18. Should we look at it from a biological standpoint? Puberty starts around the age of 9 to 13. You sort of finish your puberty between 15 to 17. Is that the time? Or do we look at brain development? So brain development matures completely around your mid-20s, so around 25 years of age, which is interesting. You can look at all these definitions, but if you want to go rent a car, they're going to say you have to be probably around 25 because we don't trust you. Looking at bone age as well, fully matures at around age 20, 25, which probably speaks to all the football players, but we won't get into that with the brain injury as well. Dr. Harshman has done a lot of work on what this means for patients suffering with chronic kidney disease. Fortunately, she's here, so I'm not really going to dwell on this. I just want to highlight to you that I have underlined many times most of your papers because there's lots of great info on there. And our patients, especially ones that have a harder road, often require extended hospitalizations, interrupted schooling, and feeling of isolation, which further increases the dependence on the adults and pediatric providers that have been there from the beginning. Many of you here have taught me this better than I can articulate to you. The socioeconomic variables for Black patients generally have worse outcomes. Faster disease progression, less likely to be registered for a transplant, especially at the age of 18 to 20 years. The patient that I presented in the beginning is not active on the transplant list. They have shorter graft survivals. Non-whites have a lower health literacy and nutritional knowledge, which is more damning for us as providers that we're not doing a good enough job to sort of deliver the care equitably. And so when there's not a lot of data out there, but there is more data on the transplant side. And so this, this systemic review of 11 studies, 10 of them were in the transplant, one study in the dialysis population of 3 patients, looking at the experience of transitioning adolescents to adult care in nephrology. And when you read the paper, it sort of breaks down to 4 major themes: preparedness, emotional attachment, adjusting to adult care, and adolescent self-care. And the preparedness was, many sort of articulated that it was like they came in one day and they're like, okay, you're ready to go, good luck. And they did not feel prepared, that nothing was sort of being built up. It was that they turned a certain age, whether it be 18 at some centers, whether it be 21 at others, and they just had to sort of move on. The emotional attachment that we talked about, some of these kids were taken care of from birth on dialysis, and they've gone through many sort of lots of complications, and being in the trenches with the families, develop this relationship, you develop this trust, and so losing that familiarity becomes a major issue. And there is a culture shock, and the really more the fear of unknown. And I've noticed this more where they're like, well, if I go to the adult side, it's just going to be different, and they're not going to care as much. Or, and I'm like, well, how do you know? I know them. They seem great. They should care for you. Or on the adult side, like they're going to come and they're just not going to, you know, they're so pampered that they're not going to be able to take care of themselves, and we have to invest so much energy. Yeah, maybe not. I mean, it's going to be very patient dependent, and I'm sure on the adult side, there are patients who are in their 50s and 60s that would be the same. So there is a lot of things that we have sort of built up in our mind, which may not actually be true, that we need to deal with. And then taking responsibility. And this was this is something that I think in pediatrics we do need to own, where they mentioned that, well, when I went on the adult side, the dialysis was my responsibility. But when I was dialyzing in the pediatric center, it was somebody else's responsibility, and I could sort of take a step back. So thinking at the, you know, why there's no cure to the teenage brain, this is data for graft failure. And the risk of graft failure increases dramatically between the age of 17 to 24. And it doesn't matter how good that kidney was, where you got it, doesn't matter your gender, your race, the cause of your kidney disease, how good things were. And so this age is a risk factor to have increased graft loss. I always think about Top Gun whenever that comes up. It is a danger zone. And so, but we can do something. And so the transition clinic that we have here, that Dr. Blosser, Dr. Smith sort of started, has been great. And what the studies showed that it sort of improves clinic attendance on the adult side, improves drug levels, and better creatinine preservation. And another Canadian study that showed that having a transition clinic makes sense economically, because you save money for the care that you need to deliver. And so it makes sense to invest some money in the transition program, because it's going to reduce cost overall. So with that background, again, we participate in the SCOPE Collaborative, almost up to 60 centers. We probably are there right now. And it started with the goal of reducing morbidity in our dialysis population, infection, and cardiovascular disease being the two main most common. Um, so that's what we focus on. But a subgroup of us sort of came together and talked about, well, let's focus in on doing some work for transitioning our patients. Fortunately, we were in Seattle, we were able to participate from the beginning, and we sort of defined the transition as an active process where the young adult acquires skills to manage their disease and navigate the complex healthcare system. And we utilize the sort of the data that's sort of out there, and there's enough, it's not a lack of resources. There's lots and lots of resources out there. It's just sort of utilizing the resources. So we felt great that we didn't have to come up with something completely new, but we did come up with something new, where we sort of came up with this framework similar to what you saw, the 6 core elements, with the goal of starting around 11 to 15 and then developing the skills over time, and then eventually transferring them to the adult side. And we broke down into 9 major domains that you can read here. And again, these were the skills that we thought we identify that we need to help them develop before they go on to the adult side, to be able to manage their disease better and be able to better articulate their cause of their end stage and articulate what their goals of care that they would want. The other work that we did is that we created handouts with the appropriate health literacy levels down to about 4th grade level, and provided that in English and Spanish to all the scope centers to be able to use. So we participated in a pilot study, which started in between February and May 2020, when we were dealing with other things at the same time. There were 6 centers, and we sort of broke it down into small, medium, and large centers to sort of give us an experience of what it would mean and what barriers would come into actually implementing a transition program. The specifics here isn't really important, except for if you look at the number of educational modules per patient per month, it was only 1 to 3 out of the 9. So what we found that it was difficult to really implement, but we were dealing with the beginnings of the COVID pandemic. But from that experience, we realized that we were working on the transition, but we should also think about a transfer tool to help the individual and the programs. And so the transfer tool was really like a play-by-play of what the patient will need to do to identify an adult provider and then successfully transfer over. So how do you what they would need to do, what kind of questions they may want to ask the center as they're making the decision, what things should get worked out before you even start at the adult center, and what would you want the new provider to know, and the pharmacy and emergency contact. We also wanted for them to be able to articulate their story, and so they create their letter and to think about their story before they go to the adult side. So we had made that available to the whole Scope Collaborative. And then we're like, okay, well, let's see what people are doing. Are they using it? So we looked at 18 months of data, and out of the close to 60 centers, only 11 centers were downloading the transition stuff. So even though we were sort of presenting multiple times, it still shows that this is hard to do. And again, you don't need to sort of read all the specifics, but you go down the welcome letter, everybody used, so intention there to get started. The least utilized was the post-assessment tool. And so many were not able to go through the full transition modules. We here at Seattle, even though we were part of the group that came up with a lot of this, we still have not had one patient that has completely gone through all the transition modules. And then when we sort of come together and say like, okay, like why is this so hard, and why can't we do this better? The things that we found of the places that seemed to be successful at doing it, they had identified a transition champion. And that champion was a key driver for successful implementation. And then the barriers towards sustainability was a lack of institutional support, as we all know. We start many of our projects as a labor of love, and that's great for the catalyst to start a new project, but you need institutional support for sustainability of any project, and that's what many programs were lacking. And then collaboration with the adult dialysis centers. Specific challenges here at Seattle Children's, there is a large geographic area. So we serve the WAMI region. We have patients in Alaska, Montana, Idaho, and all throughout Washington. And so when I think about partnership, well, who do I partner with? And is it that I make these collaborations each time? Is it reasonable for me to say, well, you've been coming here, why don't you go down the road to University of Washington for a little bit? And they're like, well, when I come to you, I've passed at least 20 adult dialysis units. What are you talking about? I don't want to do that. Patients who are financially unstable, like the patient we talked about. Patients without family support makes it harder. The hospital support, again, I think the COVID pandemic forced resources to other areas that were needed at that time. And so passion projects always are lower in their mind. And then the adult partnership, as articulated, it was hard for me to think about, well, how would we approach this? And then, you think about the enemy of good is better. And I'm like, I don't need it to be perfect. I think I just need to get it started. And so looking at the great relationship we've always had with the Northwest Kidney Centers, I reached out to Dr. Rivara and said, what can we do? Can we start with something? And let's pick this really difficult patient to start with and see. Maybe it won't work, maybe it will, and see what we can do. So this young man, we did a trial of him dialyzing in an adult unit as a transient for 3 sessions. Prior to him going there, we met as the IDT team, both in Seattle Children's and at the unit that he was going to, with the specific goals of the adult program, identifying things that the patient will need to develop, where they think that the skills that he might need to be more successful. And for him to really see all the fears of like, oh, the adult unit is going to be such and such. I'm like, well, let's go there and see yourself. And then you come back and you tell me what things that we need to sort of work on. And interestingly, things came up, like because he's homeless, the ideas came up of like, well, if he goes to the adult side, let's make sure he knows where the food banks are before he goes there, because we provide food in our unit and there's no food there. Or what's going to be the transportation that he's gonna use to sort of get there. What kind of things are a little bit different, and what things can he ask the staff when he's sort of there. And then the other things that we're considering is delaying transfer. Obviously, he's already older than 21. I'd asked the hospital for a year, and I asked them for an additional year, because as we said, the patient needs to be stable. There is nothing stable about this young man. I don't know if he'll ever be stable. And we're actively working on his story. And here, given his learning disabilities, how do you teach him to be able to articulate what conditions he has and what goals he has in his life? And he doesn't know, but we're sort of forcing him to sort of think about it. So he's huge into skateboarding. And so this is something that we will develop together, and I will give him. And the goals were for him to be able to describe what he has with pictures. So he can show his friends, so he can show any provider that he had obstructive uropathy because of posterior urethral valves. What does that mean? He had a mitrophanol when he was 2.5 years of age, and his native kidneys were removed at that age too. That he started peritoneal dialysis when he was 2.5 years old, and then got a transplant when he was almost 5 years old. but unfortunately went back to dialysis, and his transplant kidney was removed when he was 15. And we attempted to put in a graft, but that didn't go well because he had a lot of bleeding. And then he had a fistula finally created at Harborview. And here, the goal is to put down specific information that the adult provider may want of what's going to be really clinically relevant that he can sort of take with him over there. And then finally, the things that we're working on right now of what he wants folks to know about him, what he likes during dialysis, and what his goals are in life. And we're actively working on that right now. The second iteration will be to try to do longer trials and eventually try to go to do, excuse me, a trial where he wants to transfer to. So with that, the future goals is really to start younger and do this when they're 11 to 15 years of age and start and go through all the modules that we have for every patient, and really not just dialysis, but dialysis and transplant, and they go back and forth. And so really any patient with chronic kidney disease, we should be actively doing this and continue the partnership with Northwest Kidney Centers and to be bi-directional. Really, like once they transfer over, I want to know how they're doing 2, 3, 5, 10 years later. And with that bi-directional talk, I think we'll learn what we can do better in the pediatric side. And we can teach each other what maybe the resources that we need on the adult side as well for a successful transition. That's all. Take some questions. Yeah, not showing up, no matter how complex it's been, has not really been an issue. They'll show up late. They may miss rides because of they don't have the skills to sort of reschedule, things like that. But I haven't had anyone consider not showing up as a way of saying that they don't want to do dialysis anymore, and maybe they don't want to live it. They'll discuss their mortality at a younger age, but they can't conceptualize their own mortality that the way that a 60-year-old man can. They'll talk about they don't want to do this anymore. They want to die, but they still want to be able to go to the concert next year, type of thing, or in the future. So I think the best correlate would be, can they get to their next transplant? Because that gives them another sort of opportunities to manage their disease better. This young man, I don't know, I think his mortality risk is really high in the next 5 years, especially without a transplant. And given his where he is socially and the lack of support, I don't know any center that would accept him to be a transplant candidate. And so I think for us, that probably should be the goal that we get to. Yeah, great question. So we are now looking at like miles from the center. You know, obviously we have patients in Alaska and things like that. Those that don't have enough support and can't do peritoneal dialysis have to live at Ronald McDonald House. and move their families here. We actually have two families that are Native Alaskan who live at Ronald McDonald House and been living there for greater than a year. The patients that can live in Idaho, in Montana, in Alaska tend to have better family support. And so their transfer and transition actually becomes a little bit easier. But you're right, like it sort of cuts both ways. The ones that have to relocate their own whole family because they can't do it locally will need more support. Can we get them back to their own community safely? That's the other piece. And so these patients who are now living at Ronald McDonald, who hopefully eventually can go back to, one is in North Pole, Alaska, just, you know, 'tis the season. Not a lot of resources, there. And how do we set them up to be successful over there? So I think that is going to be difficult. John, I think you had a question. Yeah. Yeah. Great question. And so in the paper that I wrote when we summed up our experience in scope, we actually articulated that maybe we should be, I think we should be keeping them until their age 25. We've had patients, as you know, in our program that are 27 years old that we've kept. This patient probably will try to keep till 20, 25 and stuff. So I think there is some truth to that. You know, I think what we'll learn next is that the maturation of the brain for a healthy adult will be 25. When you add chronic kidney disease, that will be further delayed. And so how long do we keep that going? And I think what we are lacking that our adult colleagues have much more experience with is when the vintage of dials of NSAIDs is so long and the cardiovascular disease and manifestations that sort of come up towards the end of life. That's where we're always calling you to get your perspective of, you know, what am I seeing? What should I be doing? And I think when we sort of keep them longer and longer, that's also another partnership that we'll need to better manage the patient. But I do agree we should be taking care of them. Thank you. Yeah.